Ladies and gentlemen, over the next few minutes, we want to present you what we did in our group, looking at the future of the accessibility of healthcare. If you want to look at the future, of course you got to know how the present is. So at first, we looked at a few healthcare systems all over the world, and we came to certain conclusions. Market-regulated system is a way to organize healthcare. You can't just let the free market play, so everyone assures him or herself the way they want, and the state actually doesn't provide much or just a few facilities. The plain opposite is the state-controlled system, of course, with Cuba as the example. Cuba's medicine is socialistically ruled, which means it's for free. From education of doctors to hospital fees, everything's paid by government. So everyone has access to doctors. In every neighborhood there's a doctor, like as a prevention measure. The Swedish model is not similar, but it's state controlled too, so you pay part of your wage, and then, you got free access, or almost free access to healthcare. In Switzerland, we're again a special case, we're sort of mixed. We have private insurances you gotta go to, and however, the state provides a certain coverage that these insurances have to follow. Kenya also has a mixed system, as one of those developing countries that may be concerned of healthcare problems. They have lots of problems. They have no means to supply a good healthcare. So it's very, very limited down there. So of course, if you look at lots of different systems, you want to know which one is the most effective. And that's a very difficult question. So we actually focus more on emerging markets, on developing countries. But we said, well, in Western world, the Swedish model is actually very good. It's sort of fair. Everyone has access to it. Everyone pays for it. And it's available. It's affordable. So they're not complaining about their healthcare system, as it seems. So it seems to work more or less well. It's sort of more difficult in developing countries. They have no means, they need something to start with. So our idea was that, well, let's say Switzerland or European Union, well, nationally or multinationally organized insurance systems like the Swedish ones would take like just a little part of their percentage to supply developing countries with basic healthcare. Well, the definition of basic healthcare was already talked about. It's very difficult to say, but one had to define it. I mean, that should be possible. But there's a problem, of course. If you want to give money down to, not just down, it's not just southern countries, of course, but if you want to give money to developing countries, you got to be careful. What happens to the money? You don't want to finance dictators, of course. So our idea was to establish like alliances. So one country in the developed world would help a country in the developing world. Like, well, this idea was already explained too, like with the villages. So sort of a collaboration. That'd be pretty good because responsibilities would be clear. A country with a similar number of inhabitants and demographic situation, or sort of a similar demographic situation, topographic and so on, could help each other, not just financially, but also, well, technically. But of course, it's very difficult to get people paying for something. You got to show them that there's a benefit. So these countries would have to commit themselves to certain rules, let's say. Well, there's got to be a time limit, of course. We don't want to pay like, it wouldn't make sense to pay for 100 years. And for, well, I don't know, like Switzerland for Uganda, 100 years, like, and in Germany to Botswana, like 2 years, because some of them are able to restructure their economy, the others don't do nothing. So time limits have to be set, and especially certain economic numbers and social and political factors would decide when the responsibility would shift to the emerging market, to this developing country, so that it's not just the West ruling down there, but with time there would be a shift in responsibility. And of course commitments, we don't want to, as I mentioned, we don't want to finance dictators, so there's got to be certain political reforms so that we see a result, that we see that these countries are really doing something to get better. And as a general, of course, well, efficiency and responsibility, that's got to improve, because we're now sometimes wasting money, like someone said, on paperwork that's really unnecessary. And the responsibility, it doesn't make sense to finance notoric, I don't know, drinkers who just don't want to get cured. It makes sense to get that money for cancer patients, for example. So That's the basic message is let the industrialized countries help the other ones so that everyone may get healthy one day.
We realized pretty quickly that we had to make a distinction between developing and developed countries. The preconditions and needs are just too different to find one solution for both. One approach would discriminate one or the other. It became clear that it will not be possible to export the solution we have in many countries, for example in Europe, because they don't work here, they won't work there, and also they base on close links between different service providers that would have to evolve first. Therefore, we focused mainly on developing countries. Basically, there are two different approaches we have. Either we have to bring the service to the patient, or we have to bring the patient to the service. The first model we developed is bringing the patient to the service. It consists basically of four levels of service providers. First, there are the local doctors. They do basic treatment and the first triage. So they have to look if a patient has to go to hospital or if they can treat them themselves. What is very important at this stage is that the link between doctor and patient is very close to raise the willingness to follow the treatment to the end. And the second level would be local hospitals. The third level, city hospitals. They are quite big and have quite sophisticated treatment. And the last level would be specialized clinics. But the problem is that in many developing countries, there are rural areas where population density is very, very low. So this would be kind of ineffective to have a doctor for just 200 people. Even though it's normal in Switzerland, perhaps it would not be a practical approach there. So we thought that it might be better to adopt the Cuban system with the neighborhood assistance. It could be, for example, a nurse or a trained normal person, in inverted commas, who meets the very basic needs. Then a doctor could come around, for example, once a week to do a little bit more sophisticated service and to decide if someone really needs treatment, for example, in a hospital, because people have to pay much money to go to hospital, and not everyone can afford it if it's not absolutely necessary. Another thing is emergency service. The PPP doesn't seem to work, so I'll do it without it. Emergency service is always very, very expensive for every system, and it is especially difficult to get all the infrastructure needed to evolving markets. But what many people don't take into consideration is that, for example, mobile phones are available in every country. Almost anyone can afford a mobile phone. So why do we not use these services and the services provided to provide better treatment? For example, people can take photographs, or they can use the GPS system to transmit their location. It would be very beneficial to emergency care if they would not have to know how to trigger an alert, if they could just do it because it's so simple. All this system is useless if people do not follow the treatment, and this is one of the basic problems. Often they stop taking, for example, medicine if the symptoms have gone away, even though they are still sick. So very close working together between, for example, nurses and patients is needed. This close collaboration would also be a possibility to do disease monitoring. Already at a very early stage, diseases could be found and preventive measures could be taken. So I think I could give you an insight in the work we did during these 3 days. I could raise awareness for accessibility and availability in developing countries. Thank you very much.